It's the top of the hour, so we'll get started. I'd like to welcome everyone to today's GlomCon seminar. I'm Dia Waguespack in Houston, and today our talk is Tubular Toxins, Origins and Kidney Consequences. And we're excited to have our speaker, Dr. Harish Seethapathy.
Can you see this?
Yes, perfect.
Okay, awesome. Thank you so much, Dia, and thank you, GlomCon. I got a very nice introduction, so I don't have to say much. I'll just add that I don't have any disclosures. I'm going to begin my talk, but before that, I do want to wish everybody a very happy Diwali or happy Deepavali, as they say in the South. It's not often that you get invited to give a talk right on Diwali Day, so I feel blessed to do that. So what is today's talk about? It's really a melange of history of a variety of drugs that are really formative in the origin of anti-cancer therapy and the people behind them. And also, we have to talk about the kidneys as nephrologists. So how do these drugs actually affect the kidney and what do we do about them? What is this talk not about? If you're looking for a deep dive on one particular drug that affects the kidney, this is not it. This is just putting everything into perspective. So when we do that, I want to state that there's a lot of tubular toxins. Some are very similar, but others can be very different in the way that they affect the proximal tubule. These are historical drugs. These drugs, especially many of the drugs that affect the tubule, are part of the very first drugs that came on the market to actually treat cancer. Before immunotherapy, there was chemotherapy, and before that, there was radiation. But chemotherapy is really the first advent of the whole field of oncology. So I think it's kind of important to compare them. A lot of the time we talk about them in isolation. We talk about cisplatin, or we talk about methotrexate, or a phosphamide, but we don't really put them into perspective as a whole. Because the site of damage may be the same, but the hurricanes they create are sort of different. So I'll introduce our main victim here. The victim is the proximal tubule. As you know, the proximal tubule receives 20% of the glomerular filtrate, which is a lot of filtrate, right? It's around 12 liters of fluid that is almost like plasma per hour. The proximal tubule is kind of the workhorse of the nephron because it has these dense microvilli that helps reabsorb or reclaim 60 to 70% of water and salt. And it also deals with a variety of secretion of drugs and other substances via its many transporters. Due to these very high transport demands, the proximal tubule is packed. It's dense with mitochondria. And it's really dependent on aerobic metabolism and oxidative phosphorylation. So the proximal tubule has to do a lot of things. It's like a stressed mom, but compared to all the moms we know, the PT actually doesn't cope that well, so under oxidative stress, it really just kind of breaks down. So I'll introduce our heroes or villains for today, as you'd like to call them. We have 6 of them and I have names for each of them. So we'll go one by one. The first one would be methotrexate, the trailblazer or OG. The second is cisplatin. I call it the one with the multiple personality disorder. The third one is pemetrexate. I'm going to name it the Tom Wambsgans of cancer drugs for those who know Succession. If you don't know, I'll give you a brief explanation when we get to pemetrexate. Our next one is a phosphamide, or the child of war. Our 5th drug or class are the BRAF inhibitors, which I call the Insta to chemo's MySpace. And lastly, we'll spend a couple of minutes talking about CDK4/6 inhibitors. I call them the TikTok snowflakes. So let's move on to our very first drug, methotrexate. It has the most fascinating story behind it, so I think it's only right that we start with that. It all sort of begins with the curious history of folic acid. A lot of these initial cancer therapies were developed based on folic acid. Because as you see, anti-cancer therapy didn't really exist at all. All you could do is, if you see a growth, you could go in and cut it out. And then when X-rays came in, you could irradiate it. And then you had these very crude treatments like mustard gas. And for liquid tumors, you had nothing. So the survival of patients with leukemia, both adult and pediatric, was less than 1 year after diagnosis. So methotrexate.